Good afternoon, everyone, and we will be starting at 1 p.m. sharp. Good afternoon, everyone. Welcome to MEPD's final webinar for this year, 2023. It's with great pleasure today that I introduce Dr. Dawa Malar, our speaker for today. Dr. Dawa Malar actually graduated with a doctorate in clinical dentistry from UKM in 2014 and is currently working in Malacca. She has extensive experience in handling cases for autotransplant, and she is someone that is always, keeping herself updated with the current and recent developments in the world of autotransplant. She's also my go-to person when I have any questions or queries regarding autotransplant because she's always updated. So it's with great pleasure that I welcome Dr. Dawa Malar to deliver her presentation today. We reserve the questions for the very final 10 minutes of this webinar, and we can always post up the messages and the questions on the chat box as well. And we will get to it once the webinar is done. So over to you, Dr. Malar.
Good afternoon, and thank you, Dr. Tharani. I must say that I must correct you a little. I am rather new to autotransplantation. I'm not expert. I think if an expert, probably Dr. Sarima. Yeah. So, but I am learning. We got to learn. We got to move on. And autotransplantation is an alternative option. Besides, especially in young children, whereby you can't do implants and everything. So I will share what I've learned, so far, and there's a lot more to learn, lot more to do. My case is just few, not and sorry. Okay. Yeah. So anyway, thank you, Dr. Tara, for the intro. Before I start, I would just like to thank my HOD and also my colleagues, my perio colleagues here, from whom I've learned how to manage tissues, grafts, and how to handle bone grafts. In fact, we have done a case together. So it's a great exposure and great learning process. I hope you all get to do the same with your perio colleagues. Yeah, and they are good with management of management of soft tissues and the link, All right. Can I share my slide now?
Yes, doctor, sure. You can share your slides.
Okay, can you see? Can everyone?
Yes, we
Sarah?
can. Yes,
Okay,
we
right.
can, doctor.
Okay. All right. So actually, autotransplantation of teeth is like the current treatment of choice. It has been there for some time, but not many of us are doing it. But it is like if you see a lot of articles about autotransplantation where they are telling that it's a good alternative option for children, especially and adolescent, to replace their missing teeth. So I think we should embark on it. So I shall proceed with that, and I'll just share what I've known. Okay, my lecture will have a bit of introduction on autotransplantation and how do we go about examining and coming up with diagnosis and choosing our patient. Before we actually choose, we need to know whether the patient is suitable. Before we decide to do an autotransplantation, we need to know whether the patient is suitable for the process, for the procedure. And besides other indications, besides the patient themselves, and what do we need to prepare, I will discuss on it. And I will also briefly describe on the factors that contributing to the success and survival of the autotransplantation. Okay, because autotransplantation is deemed as technique sensitive. Okay. An advantage of it, basically compared to implants, okay, and just summary. Okay. All right, autotransplantation is defined as a replacement of a tooth with another functional tooth within the patient's dentition. Okay, this slide. Okay, so the donor tooth can be erupted or is embedded or impacted. Okay. Actually, the breakthrough was about in the early 1950s, where the first molar was with severe dental caries was replaced with third molar. It initially started with third molar autotransplantation, which because at that with the immature root formation. But however, probably because of lack of proper comprehension of the biology of the autotransplantation, it has caused the success rate was a bit low, and it discouraged many dentists at that time. Not knowing how to go do a proper, delicate treatment. What are the factors that involved in it? And also, I would say lack of technologies. Okay, would have actually caused the success rate a bit lower. Not understanding the biology of it that actually discouraged many dentists from going on with this autotransplant. Okay, according to Sukiboshi, he classified autotransplantation into 3 categories: conventional. Sorry, I need to minimize my. Okay, conventional transplantation. That is moving the teeth surgically from one side to another side in the same individual, probably one socket to another socket, whereby the recipient side, the tooth is indicated to be hopeless, with a hopeless prognosis, and the donor tooth can be used without any negative effects from the loss of its position in its arch. The other type would be intra-alveolar transplantation, whereby the tooth is within the original socket. probably just rotated or extruded out, or probably slightly replaced or whatever, we are just going to surgically upright it. Okay, so sort of like we remove it and then we upright it. Okay, that's intra-alveolar transplantation. And the third one, sorry about the numbering. The third one will be intentional replantation, whereby it's basically to solve the endodontic problem, where you can't solve it by non-surgical or surgical approach. For example, where the tooth has to be extracted and you had to do the episectomy of sort of 3 mm of the apex has to be cut off and retrofill before you place back the tooth into the original position. For example, if it's a molar with unresolving periapital lesion, but if it's in a good condition, so probably they will just extract, do the episectomy, and then reposition it back. Because to do, depending probably the position of the tooth or probably the thick buccal cortical, preventing it to have for us to do from direct episectomy. Okay, as I've said, autotransplantation is technique-sensitive procedure. So, however, it offers a biological replacement option to patients compared to bridge implants. It's patient's own teeth, and I have not read transplantation from another person to another patient, but mostly it's done within the patient's own mouth. So it adapts well to the patient's within the patient's bone. Okay? And however, it requires a proper and thorough planning as well as careful and knowledgeable execution, so that we can increase the success and survival of the transplanted tooth. So in children and adolescents, basically autotransplantation is used to replace the traumatized maxillary anterior incisors that have poor prognosis, knowing that when a child has trauma, sustains trauma to the upper anterior, most commonly the teeth that bears the brunt is the upper anterior incisors. And if it's advanced or it undergoes any sort of replacement resorption and cannot be salvaged, so we can opt to do a transplant, especially using a premolar, and if you find that the child has basically a crowded dentition. Okay. Also, autotransplantation also used as a hypodontia management plan. It's part of the interdisciplinary management to redistribute the teeth into strategic location, especially if you find that upper anteriors, the whole maxillary anterior ridge has no teeth, and you have teeth only at the posterior. Probably we can opt to distribute, take some of the tooth there to replant into the anterior side, for an example. Okay. Thirdly, also we can use autotransplantation for ectopic teeth. For example, canines, as part of comprehensive orthodontic treatment, whereby it might prolong the orthodontic treatment to bring down the canine, or canine is in a transposed position where realigning them back into position will cause more damage to the adjacent teeth. Then autotransplantation will be an option for this ectopic teeth. However, in adults, mostly third molars are used as an autotransplanted tooth to replace other permanent molars which are lost due to caries or periodontal disease or endodontic infections. Okay. In adults, it's mainly all younger adults, mainly third molars, because that's a tooth that may have a foramen apex that's still open, about more than 1 mm compared to the rest of the teeth. Okay, so when coming to the examination and diagnosis, when you are selecting a patient, we have to include the factors such as general health, the psychological behavior of the patient, and their willingness to undergo the procedure, especially, and also the oral hygiene status. Especially in young children, they must be willing to withstand the procedure and also able to follow the instructions given and follow the oral hygiene properly, diligently, and then the recipient tooth and the donor teeth need to be examined carefully with the radiograph. And cone beam CT, with the presence of cone beam CT, I think we should make use of it because it gives an excellent 3D view, and we can do measurements of the tooth, and as well we can evaluate the thickness of the bone at the recipient side, the amount of bone that's available, the width of the bone, the height of the bone to receive the donor tooth. So CBCT gives a good picture. So if you are deciding to do an autotransplantation, it's good to do a CBCT of the donor side as well as the recipient side. Okay. You will need clinical photographs, of course, and we need to make sure we need to do the probing depths to make sure if there's any pocketing, and then and other clinical parameters, whether there's the mobility, there's any crowding, caries, and how many teeth we need to see. If in a hypodontia cases, where would be the ideal place for you to place this donor tooth? It's important to know. Okay. So sometimes you need to work with orthodontists as well to decide where we could place the tooth for them to have for them to do the rearrange open space or closed space accordingly. Okay. And also we need to know the condition of the socket at the recipient site, whether there is a bone loss, okay, the morphology and the stage of the root development of the donor tooth also is very important. It is said, I will go in deeper further on the morphology of the tooth, because it is said that a single root, conical shaped, has higher success compared to multiple root in autotransplantation. Okay. Autotransplantation also determined as a suitable treatment modality when the case has matched the indication cited. Okay. So next I will go on to the indications more specifically. Okay. See, in the case, as in here, you can see the presence of a hopeless tooth, 346, and there is a suitable and spared able donor teeth, is either such as premolars or third molars, the same mouth can be used as a donor tooth. As in example here, you can see this picture I took from Sukiboshi, his paper, where he actually transplanted 4-8 into the 4-6 socket. Okay, he has, because 4-6 was removed and he transplanted the 4-8 into that socket. So the surgical side is restricted to one side. And if you can see, probably he chose the 4-8 because it's a bit more upright, easier for removal compared to the 3-8, which is more mesiolingually impacted, and you may have a difficult extraction, and in the event you might injure the PDL or the tooth itself. Okay, so when you are actually deciding which tooth to remove, take it as a donor, we have to carefully see the position of the tooth, how minimally with minimal, I would say with minimal trauma, you can remove the donor tooth. Are some of the factors you have to consider. Okay, preferably the other indication, the donor tooth has a simple and easy to extract form. But as I've said earlier, is preferably it should be single rooted, conical or bullet shaped, because studies have shown that a success rate and survival rate is higher in these teeth with single rooted compared to multi rooted. Okay, and the bone width of the recipient side also should be wide enough to accommodate the donor tooth. So you can't transplant a molar tooth into the incisor region, obviously. So, and then the incisor region, commonly we tend to transplant mandibular premolars, usually second mandibular premolars, because their roots are a bit more conical. So as I've pictured here, you need to measure how much of a bone left, the width, the height, whether you can accommodate the length of the donor tooth. So other indications will be the maxillary incisors, which are involved in trauma, and the tooth is lost or it undergoes replacement resorption. So commonly in this area, as a replacement, the mandibular second premolars are always the first choice to replace them because of the root anatomy. It's about similar to the anterior upper and central incisors. And this, if you look through the literature, many cases have been done whereby the central incisors are replaced by the premolars. And then later part, it will be modified to the shape of the incisor itself. Okay. Other than that, Sukiboshi et al. He said that it's preferably it'd be good to do. It'd be better to do a autotransplantation in patients less than 30 years old, especially if the donor tooth is completely developed. Of course, at that age, you would expect the donor tooth to be completely developed. So try not to exceed more than 30 years old. But there are cases done above 30 years old. We found that that paper says it has a mixed reviews. Some say it doesn't last the success rate is lower, but the survival rate is longer. So timing is critical when assessing the root formation stage, suitable for autotransplantation. Therefore, the age of the patient must be considered when planning for autotransplantation. Because in immature tooth, we can pulp regeneration can be expected, but of course not in mature tooth. Okay. Most of the root development occurs between the age of 9 to 12. Okay, and if you see that most of the trauma among children also happens around that age, so that's why we tend to have these premolars. They are more of like a victim of circumstances, whereby when you lose the central incisors and the premolars are there at the right stage of root, and probably if they are crowded, they can be used as replacement for the anterior maxillary incisors. Okay. However, wisdom tooth as replacement of failed molars is better to be transplanted in an elder tooth, because of course, in a young children, the wisdom tooth is not fully formed yet. Okay, the root stage is still below 4. Okay, if you follow the Mori stage, root stage is below 4. Other than that, autotransplantation can be done when it is found more advantageous than doing other treatments such as implants or bridges or removable dentures in terms of treatment duration, the cost, or the aesthetics per se, whether we can preserve them longer, and whether it's accepted more better biologically. If you find that most of these papers stated that patient acceptance is better in autotransplanted tooth rather than implant. However, just based on the success rate, whereby they see whether the tooth undergoes full maturation of the root, or whether the tooth has replacement resorption or becomes the pulp becomes obliterated. So therefore, the success rate it becomes lower. However, it tends to last longer in the mouth. That's why the survival rate tend to be longer. So as you can see in this child, this is one of our patient, which we haven't done. We are planning. We thought we could discuss to have the tooth auto-transplanted, where as you can see, the tooth lateral 1, 2, 2, 2, sorry, is not has not erupted. And sorry about the x-rays, because before I could take the picture properly, the CD has been given to the ortho. So the 6-2 is still intact, and if you can see, there are odontum, okay, multiple denticles that's preventing the 1-2-2 from erupting. So in this case, if you can see, the patient has a well-aligned arch. In fact, he has spacing, okay. So for us to do a treatment, fixed appliances for him, it might cost him more, and it might take longer time. So this might be in a ideal case for you to do an autotransplantation, whereby you can remove the odontum, and then you can reposition the 2-2 into the socket of at the socket of 6-2. Okay, so also it depends patient's hygiene, patient's acceptance, and whether the parents are willing to, the child is willing to go through the procedure. Okay. Okay, the other indication is based on the maturity of the root. It is stated the optimal stage for the development of the root of the donor tooth is between the MODY stage 4 to stage 5. However, the stage 6 also is acceptable as long as the diameter of the apical foramen is about 1 mm or more. At stage 4, basically the roots develop along the entire length of with the open apices, while in the stage 5, the root apices are half closed by a wide parental ligament. Okay. When it's too immature, it's not possible to do autotransplantation, because we may end up with a stunted root. Okay, and then this might compromise on the fixation of the tooth itself within the bone. Okay, the other indication will be as I think this I've said earlier also, where autotransplantation may provide a simplified or faster treatment option with patients ectopically positioned or impacted teeth. This was one of the cases done in HCL during the advanced surgical course. I would like to share here, whereby the 2-1 was impacted because of the presence of the odonto, and the root of 6-1 and 6-2 were still there. So it was decided to, and patient did not opt for fixed appliances. So it was decided to auto-transplant the 2-1 into the socket. Okay. So, and besides the patients, the rest of the dentition are well aligned. Okay. All right. The factors that are involved in the success, the healing of the autotransplanted tooth, there are many factors. From the beginning, from the time you're examining the child, and deciding whether the child or the patient is suitable for the autotransplantation, it is itself a factor. So it starts from identifying the right patient. So it is said that younger patient gives a better result, and patient preferably must be free of major systemic or metabolic problems. Okay, and they shouldn't be having this. They shouldn't be smokers, or and who can also can take care of their oral hygiene well, and they should have a cooperative attitude. Okay, we don't want a patient who's not compliant to the oral hygiene instructions, who's not compliant with the treatment we are giving, and who are not compliant with a number of visits we are requesting. Okay, so all this has to be discussed with the patient before I actually embark on the treatment itself. Okay, the other factor will be the donor tooth itself. Periodontal ligament plays a very important role in the autotransplantation because the PDL itself, if we need the PDL to be intact and vital so that it can attach to the roots of, it must be attached to the root surface. And so that when you are transplanting the donor tooth to the recipient side, the PDL are still viable and able to differentiate into osteoblast or symptoblast, and there is and it can not fuse, but it can adhere to the adjacent bone, so it's very important to remove the tooth in a traumatic way so that the PDLs are intact. Okay, and it's also said that they should have a shorter extra-alveolar time so that the vital PDLs are preserved. Okay, so if you had to remove it and put it out, leave it out for a while, try not to be longer than 18 minutes. That's what Suki Boshi suggested. And you must preferably place them in the physiological salt water or milk or any preservation liquids. Okay, so that you should not allow it to be dry. Okay, the other option will be putting it into the when you open up a flap, the buccal sulcus, or into the between the bone and the flap. But make sure you don't lose it, right? That's one thing, and make sure there's no contamination to the root itself. Okay, that's why it is suggested that when you do CBCT, you can actually do a 3D splint, surgical splint using the 3D, so that you don't actually have to use the donor tooth itself to try it, but you can use the surgical stent or splint. Okay? The enhanced healing of the gingival tissue, it said that, the gingival tissue's healing is enhanced by placing 1 millimeter band of PDL fibers on the root above the crestal bone. There's one way of that suggestion by the literatures, by the studies. Okay? Another thing is that having a PDL, especially in a non-eruptive tooth that embedded, there is a chance of having this PDL to be to keep it intact so that they can be replaced into the donor site, and with the hope that it can differentiate and into a and keep on into a cementoblast or into a osteoblast so that it can adhere to the socket. Okay, so even if it's a non-functioning tooth or if it's a embedded impacted tooth, try not to remove the PDL cells. Okay, the other thing is that healing of healing of the, I'm seeing my screen, sorry. Okay, healing of the dental pulp. So it is said that by preserving the hydric epithelial root sheet, we can help to preserve the dental pulp, because and especially if the root development is either stage 4 or stage 5, the chances of the dental pulp to be preserved is higher. Okay. And also it's stated that there is chance of about 87% of chance of dental pulp to heal when the diameter of apical foramina is more than 1 mm. Okay. Other factors will be like ideal timing of transplantation, whereby the root of the donor tooth should be about 3 to 4 or 4 to 5 complete before we actually do the transplantation, so that it allows the continuation of root development and adequate root length. Okay. During the closure of at the recipient site, it is suggested that you need to have a tight flap adaptation and suture tight, watertight, so that to prevent a bacterial infection, because at the recipient site, the socket tend to be a bit larger than the tooth itself. So your tooth tend to be a bit mobile, and they have a space between the bone and the root itself. So it is better to, that's why you have to adapt the gingival valve and suture it tightly. Okay. And this I've mentioned earlier, that the root morphology of the donor tooth itself, if it's a single and cone-shaped and without concavity, is more favorable than compared to multi-rooted. At the recipient sites, there need to be adequate bone width and height, okay, so that it can receive the donor tooth, meaning that the donor tooth should have enough adequate bone surrounding it, not that the buccal bone lost or there is a thinning bone, okay, because the PDL need to have a bone to be attached, okay. So that's that, and it needs the bone is needed by the PDL tissue as well for better healing. Okay. And timing, based on the timing of autotransplantation, is preferably to do the autotransplantation on the same day as the removal, because then the higher chances of maintaining the bone width, the bone height, as well as the PDL cells within the recipient site is higher. Okay, unless there are times where you need to, there is a severe infection, where you need to allow the recipient site to recover, heal, then do not take more than a month after the extraction, because you tend to lose the bone width, basically the bone width and the PDL cells. Okay, so you end up creating a new socket again. So the timing is very important, and ideally it is said it would be the same time as you remove the tooth, and the transplantation should be done at the same time. Okay, other important steps, this I've said earlier, with the advanced technology, CBCT, we can create a replica, okay, of the tooth, the donor tooth, whereby it will minimize the mechanical damage to the periodontal ligament of the donor tooth during the trying period. Because every time you're going to remove the donor tooth and put it into the socket, and you're going to compress it, they actually tend to damage the PDL cells. And you're going to take it out and then widen the socket and try it again. So every time you're going to try it and you're going to leave it outside, actually it's adding to the damage to the PDL cells. So it will be wise to have a surgical stent or replica to it, and so that when you remove it, and it can, when you remove the donor tooth, it can be repositioned immediately into the recipient site. Okay. And of course, before the surgery itself, you must make sure the oral cavity is disinfected. There is no plaque, mud, or patient has a good oral hygiene, no calculus, and the surgical field is healthy, no infections, or no it's an optimum state, optimum level. Okay. And always remember that you always remove the hopeless tooth at the recipient side first before you actually take out the donor tooth. in and try it on. Okay, and always, whether it's in the recipient side or the donor tooth, both sides is preferably try to preserve the periodontal ligament on both sides, because at the recipient sides there are periodontal PDL cells attached to the bones of the sockets, the bone surface of the socket, and when the donor tooth also will have the PDL cells, so it will actually enhance the healing process of the PDL cells, thus reduce the chances of the tooth undergoing replacement resorption or inflammatory resorption. Okay. Okay. Other than that, the other new thing that been suggested, that had been in the literature, in the studies they've been tried, is that placing regenerative materials such as PRP, plasma-rich, platelet-rich plasma, or CGF, concentrated growth factors, as scaffold material within the alveolus at the recipient side in order to favor the revascularization of the transplanted tooth. It has been done, and it is shown has a better survival rate and success rate. Okay, and also if the quality and the quantity of the recipient side of the alveolar bone is inadequate, and even by placement of these autologous bone graft or membranes actually will help with the periodontal healing of the transplant. Okay, in a study done by Imazato, 2004, he found out that autotransplantation of the wisdom tooth to the position of the first molar with a moderate to extensive loss of bone at the buccal alveolar plate, when he placed the GTR membrane coverage with or without bone graft, there were absence of alveolar bone plates. Sorry, where there were absence of alveolar bone plates and there were exposed roots, now were covered by new formed bone. That means the donor tooth were actually covered by a new bone at the part where there was no bone initially. However, on the cases where there was no GTR or bone graft was placed, there were no bone formation noted. Okay, so this actually increases the chance. This actually causes replacement resorption. Increases the chance of replacement resorption. Okay, I'd just like to share you a case. This case was done together with the perio, an 11-year-old boy with hypodontia. I didn't want to show the full face of the child because I think this video will be uploaded in the FB, right? So he has actually congenitally missing many permanent tooth, especially at the anterior where he doesn't have 1, 2, 1, 1, and 2, 1, and even 1, 3 wasn't present. And if you look at the lower anterior region, he has all the 4 primary teeth as well as his primary canines where he has a good root. His 3-2 lower lateral incisors were just about to erupt, and his canine 4-3 has a good root. So for him, if you can see, there's a knife-edged upper anterior ridge. Okay, for him, we've decided to do a bone augmentation. Together, at the same time, we decided to do a autotransplantation of tooth 4-3 into the position of 1-2. Because it was so thin, the bone, we decided to place near at 1-2 region compared to the 1-1 region. Okay, which would have been ideal, but nevertheless, this was quite satisfactory. We had to do the bone augmentation together at the same sitting as the autotransplantation because we were doing it under GA. Ideally, it'd be good to do a bone augmentation before we do the autotransplantation. Okay, so at the moment, as of now, the tooth 4-3 has been modified into lateral, and he had a conical-shaped supernumerary at the 2-2 region, which was also modified into a lateral, and he was given a denture to replace the 1-1 and 2-1. Basically, he has a microdont as well. So, however, he's now a happy patient. Before he was very shy. He hardly goes out to play with his friends. Now, according to the mother, he smiles widely. He mixes with his friends without without any fear being bullied or laughed at. So this is something we would like to see. We like to do in a patients with hypodontia. Okay, and this case actually was discussed with Otto as well. So we decided to preserve as much as the permanent and primary tooth as well. So this was the radiograph of the 4-3, which was transplanted into the 1-2 region at 1 month post-operative. And at the 8-month post-operative, you can see actually a nice lamina dura space, PDS space around the tooth that has formed. The root, the dentin appeared to be more, the root appeared to be more thicker compared to 1 month ago, but it's still not fully closed apex. Okay. All right, this was the child, another child which I actually showed earlier, where she has odontome impacted 2-1 due to the presence of odontome, and there's a retained 6-1 and 6-2. The 6-1 and 6-2 were removed, the odontome was removed, and we had to place bone graft and GTR to fill up the big cavity that was left behind by the odontome. Okay, so that and autotransplant the 2-1 at that region, because so that the 2-1 is not floating, and it's more stable. So, however, of course, it was expected the 2-1, it was a closed step. It was not fully, it was closed, stage 6 Morris, Morris stage 6 root, but yet there was a small foramen, the foramen was a bit about 1 mm, I think probably more, but it did, when we did the APT, it didn't respond to the APT, so we proceeded with the RCT. Because it's considered as a closed apex, okay? And at the same time, the 1-1 also had a history of trauma before, so that also has to, the root treatment has to be done on the 1-1 as well. So at the moment, the child didn't have to undergo any dental treatment, and this is at the 6 months. Picture was taken at the 6 months post-op. All right, preparation of socket should be larger than the donor, than the donor socket, and preferably it should be done either by implant burst or round surgical burst at low speed and with cooling and saline solution to reduce much damage to the PDL cells. Okay. In my case, where it is said that piezo trimmer causes less damage, less damage to the socket. Okay. Autotransplantation of teeth with open apices has been said to consistently demonstrate better success and survival outcomes, and lower risks of pulpal necrosis and external root resorption compared to the closed apices. So it is recommended to choose a tooth with open apices, preferably stage 4 or 5. Okay, and The other factor that also plays a part in the survival and success rate of autotransplanted tooth is the type and the duration of the splinting. It is suggested that to use a non-rigid or flexible splint compared to rigid splint. If you are using a composite wire splint, try not to use the 0.5 or 0.6. Use a 0.4. Okay, it's much flexible. There are cases done where just by placing a sutures over the tooth, but then sometimes it doesn't give because the socket tend to be bigger than the donor tooth itself. So sometimes the suture alone may not give the fixation to the tooth. So sometimes you need to have a splint placed. Okay. And also another thing is post-operatively, antibiotic cover is important because studies have shown that treatment failure found to be greater in cases without antibiotic cover. All right, other than that, as a normal usual stuff, the post-operative management, where we have to be strict with the oral hygiene. We have to prescribe them or fluoxetine mouthwash, and suggest them to eat a liquid diet and soft food, antibiotic cover, and the use of anti-inflammatory drugs to reduce the inflammation around the surgical site. Okay, and then even if it's a closed apex, then RCT is suggested to be started after 2 weeks of transplantation. Okay. Post-operatively, we have to monitor these patients quite often initially, probably the first week to remove the sutures, threads, okay, and then evaluate the surgical sites, whether you need to prolong the splinting. Okay, second week, if the patient and the tooth is rigid, not so mobile, you think you can remove the splint, then you can remove the splint, okay, and then you can start the endodontic treatment, and then re-evaluate the tooth at first 1 month, 3 months, 6 months, and so on, okay, to evaluate the mobility, to check on the sensitivity to the percussion, the probing depth, and also evaluate radiographically for any signs of inflammation or bone resorption or periapical changes. Okay. Okay. So just to share you before quickly, dental implant, the differences between dental implant and the autotransplant is that dental implant can only be done after the bone growth is completed. However, in transplant, there's no patient age limit, but of course it's suggested to be done below 30 years old. But if the patient is older than 40 years old, it is said that implant has a better success rate. Okay, but patient's acceptance and aesthetics is still under par compared to the autotransplant. Okay. Dental implant doesn't have a PDL, it doesn't cause bone induction, okay? And also eruption is not possible. And so that's why it's a disadvantage to growing patients. And there's a prosthetic treatment is required and you can't adjust them, okay? And it also is basically a first choice only for completely dangerous patient, okay? Whereas in autotransplant tooth, the tooth has a normal PDL and it can serve as a shock absorber and a proprioceptor. In fact, it can promote bone. It can even allow normal eruption, and that the tooth can be, if needed, orthodontic treatment to adjust the movement, it can still do it. But most of the time, orthodontic treatment are done and the space is created before the autotransplant. Okay, and just that it needs an ideal donor tooth. Okay, gingiva, normal gingival contour is problematic in implant cases, especially when they are placing 2 implants adjacent to each other. However, in autotransplant cases, you can get a normal gingival contour. Okay, you can't move implant orthodontically. However, in autotransplanted tooth, if it's there's no replacement resorption, it can be moved orthodontically. Of course, implant needs an osseointegration stage before we do the prosthodontic treatment, and it is more expensive compared to the autotransplant itself. Okay, implant has been said that has a high survival rate in older patients. However, in adolescent and younger children, they are a bit low. Meanwhile, in autotransplant, survival rate is higher, about 95 or almost and 100% at 5 years and 10 years. Success rate, they say, slightly lower compared to survival rate because there's no standardized criteria. Even there is some studies says that even there's a pulp canal obliteration is considered as a low success rate. Okay. All right, coming towards the end. All right, so as I've said, there is no standardized evaluation of success and survival rate in the literature, in the papers that have been published. So, but success rate basically measured by the pulp revascularization, and or if it's a mature tooth, it successfully can do proper endodontic treatment, and if it has a favorable periodontal healing and it allows normal bone growth. Meanwhile, survival rate is assessed by have a presence of the tooth in the final position, at that position that it has been placed initially, until and regardless of the clinical or radiographic outcomes. That means it is remained at the position we have planted and it is functional. Okay, in summary, autotransplantation actually can serve as a promising treatment alternative in case of tooth loss, not only in children and adolescents, but also in adult patients. However, proper planning and careful execution of the procedure are important to achieve optimal long-term results. All right, but these are my references, and thank you.
Thank you so much, Dr. Muller, for your such an interesting sharing session. And there's quite a number of questions here by the participants. Okay, so the first one is, they all want to hear from you, like, how do you, okay, so Dr. Faisal has asked, how do we get the replica, as in like the stent? Do you need to have a specific machine, doctor?
Specific what?
Do you need to have a specific machine to do the stent?
Oh yeah, you need to have that 3D printing machine, you know, you need to have, yeah.
Okay.
Some of the oral surgeons have, or you can just send it out for the printing, you know, private. Some of the companies, yeah, you need to have a specific machine, yes. Okay. The one I did was I had to send to JB to do the 3D printing.
Okay. Another one has direct messaged me. She said that she's confused because she said that auto transplant can be performed up to 1 month after the extraction, but then the extra alveolar time, the best one is actually 18 minutes. So how does that work? I think one of the slides you mentioned that some literature said that you can actually do auto transplant even 1 month after the extraction.
Yeah, meaning that you don't extract the donor tooth. You just extract the recipient side, the hopeless tooth or unfavorable tooth first, and leave the socket to heal, you know. And then on the day when you want auto transplant, then only you remove the donor tooth to the recipient side. That's what I meant. Means you don't disturb the donor tooth at all, but you don't leave the recipient side more than a month. Mean that because if you have loss of bone width, when you extract the tooth, your bone will tend to collapse, right? The alveolar bone will collapse. So you lose the socket, and then you have to create a new socket again. So that's why, but that's what I meant, okay? Means that you're not going to take out the donor tooth and keep it outside, no.
Okay, thank you, doctor. Now there's another question from Dr. Haziq from Hospital Seberang Jaya in Pulau Pinang. So what he asked is that regarding orthodontic preloading prior to auto transplantation. So he says that, you know, there's some literature says there's like the success rate is quite high to do the orthodontic preloading prior to auto transplantation. So because the preloading will enhance the PDL tissue and facilitate removal of the donor teeth. So if you plan to do this prior to autotransplant, what's your recommendation of the period to wait for orthodontic preloading, as a wide range of timing is found in literature? Some say 2 weeks up to 3 months. So what is the time that you wait if, let's say, you were to do orthodontic preloading prior to the autotransplant?
I mean, when you do the orthodontic treatment prior to autotransplant, you mean?
Yes.
Okay. Usually, most of the time, my personal opinion is that orthodontic preloading should be done. I have not done any of the patients immediately after orthodontic treatment. Most of the time, we try not to. You do the orthodontic treatment, create a space before you do the orthodontic. You do the transplant, and after the autotransplant done, then we don't disturb the tooth for some time. Don't move the tooth. So I don't understand the part where what he meant by orthodontic preloading.
Yeah. Dr. Haziq, are you there? Do you want to ask
Yes.
yourself? Yes, okay.
Can you hear me?
Yes, I can hear you, Dr. Haziq.
Thank you, Dr. Tavamala, for the seminar. So what I meant about the orthodontic preloading is that if you want to choose, for example, the premolars to be as a donor tooth to replace the anterior, in this case maybe the tooth 1-1. So prior to extracting the premolar, some authors suggested that we do some orthodontic preloading, meaning we put some pressure, meaning the patient will be fixed with fixed appliance, and then put a pressure on the premolar. Some, like I mentioned in my question, some article, they just do it for about 2 to 4 weeks prior to extracting the premolars. And some, there's some case report, they do the orthodontic preloading up to 3 months prior to extraction and then do the replantation of the premolar. So because of the wide range of suggestions, so that's why I need your view on this.
Okay, I get you now. Okay, I've read about it. Personally, I have no experience on that, Dr. Haziq, because practically when patient comes to us, we try not to put, the basic idea is that not to put the child, to reduce the treatment time, duration for the patient. So I have not done any of this orthodontic preloading because most of the time we try to cut the treatment expenses, cost for the patient, as well as the for the patient's benefit as well. So basically, I'm sorry, I have to say that I don't have experience on doing the orthodontic preloading. I understand, I've read the articles, but no, I have not done. And whether it's successful or not, I'm not sure, because I have not done personally. Actually, in the literature, they have so many suggestions because it's still a new thing and they are trying so many things. But I have not done it. So I can't answer that whether it's better to do orthodontic preloading or not. Okay. Basically, when the patient comes, like one I've showed that when the patient refused orthodontic treatment, I can't go and force orthodontic treatment on her. So we opt for another easier way option. Okay. And in a child with hypodontia, there's not much of teeth for us to place fixed appliances. So we don't opt for orthodontic treatment there as well at this moment, because many of his permanence has not erupted. So I'm so sorry I could not answer that question, whether it's better or not.
Thank you so much, Dr. Tavamala. Due to the lack of time, because it's almost 2:02 now, I will ask that all the other questions be forwarded to the MEPD email, and then I will get Dr. Tavamala to answer them, and then I'll probably email back the recipients after that. Is that okay?
Right.
Okay, so sure. Thank you so much, Dr. Mara, for today. It's been so insightful. As you can see, I'm getting a lot of direct messages. They're not putting it in the chat box. They're actually asking me. I'm like,
okay, I will.
I will. I don't know why they're direct.
Yes. Yeah, he came up with the orthodontic preloading thing. Yes, I've read. we never actually gave it a thought. It's a good question, yes, but I must say I never opted for that thing, because it's in trial still, yes.
So thank you so much, Doctor. They will drop me some emails. I'll probably get back to you by the end of the month once I've collected everything, and I'll send it to you.
Okay.
Thank you so much for today. And thank you again for PPD for actually coming and spending time during lunch hour. And it was so difficult to actually get you because you're so busy. You had so many meetings and things like that. So finally you managed to settle. No, it was like we were planning for some time, and then of course you had meetings, we had meetings, and we had so many things, but we're so happy we actually got this done today. So thank you so much. Everyone, please sign in with the attendance link. Thank you, Dr. Malar. Thank you so much for today.
Thank you, Dr. Tara. Thank you. Thank you, everyone.
All right. So we will off now.